Hello, this is Dr. Grant Cooper from Princeton Spine and Joint Center. In the next 9 minutes, I'm going to tell you everything you need to know about Piriformis syndrome. 9 minutes isn't a long time, and this is important information, and we're not going to be cutting any corners, so let's get started. The piriformis muscle is a deep muscle in the buttock that attaches from the sacrum to the femur. In piriformis syndrome, the piriformis muscle itself goes into a spasm and becomes painful. Sometimes the muscle also irritates the sciatic nerve that passes right by or at times through the muscles. The symptoms of piriformis syndrome typically involve buttock pain that's located along the piriformis muscle, although sometimes you'll feel it throughout the whole buttock. And if the sciatic nerve is involved, then there will also be pain radiating into the posterior thigh, calf, and foot, tracing the course of the sciatic nerve. Now, this syndrome can occur in anyone, but at the outset, let's make the point that while the symptoms of piriformis syndrome are very common, it's relatively rare to have true piriformis syndrome. Let me explain. Statistically, piriformis syndrome is much less common than a pinched nerve in the back from, for example, a herniated disc or a spinal stenosis. In fact, the L5-S1 disc is the most commonly herniated disc in the back, and the L5 and S1 nerve roots join together and form the bulk of the sciatic nerve. So a symptomatic herniated disc or spinal stenosis at that level, the L5-S1, and piriformis syndrome can clinically look identical. Further, a branch of the L5 nerve innervates the piriformis muscle, so when the L5 nerve root's inflamed, it's very common that the piriformis muscle will spasm as a protective reflex. Now, because they look the same clinically, it's very easy to see how easy it can be to confuse the two conditions. And indeed, they often are confused. In the past, before we knew all that we know now, piriformis syndrome was wildly overdiagnosed. And you can imagine how this happened. If someone has a pinched nerve in the back and the piriformis muscle spasms as a result, and you massage the piriformis muscle and it feels better, then you think you found the problem. But then the piriformis muscle spasms again a day later or so because the muscle is still responding to the inflamed nerve root. And so you think it's a difficult to treat piriformis spasm and you massage it again, or you inject it with a trigger point injection. And again, it feels better. And again, the pain returns a few days later. Now, because disc herniations and spinal nerve root inflammation is statistically so much more common, to the tune of about 98%, today we understand that it is reasonable to assume that pain in the piriformis muscle and then pain radiating down the back of the leg is in fact an inflamed nerve root coming from the back until proven otherwise. But how do we go about figuring it all out? Well, first, clinically, we look at when the pain is experienced. If the pain is worse with sitting and bending forward, this would suggest it's more likely coming from a disc. If the pain is relieved with bending forward, but predictably feels worse with bending backwards, then this would suggest that there's foraminal stenosis from spinal stenosis, basically arthritis, in the back of the spine that is impinging and leading to inflammation of the nerve where the nerves exit. On the other hand, if the pain is less predictable, and if the pain is worse in general with climbing stairs or walking uphill, then this starts to suggest piriformis syndrome as a potential cause. Let's look at the important diagnostic studies now. If on MRI, the L5 and or the S1 nerve root look impinged, this starts to argue towards the problem coming from the back. On the other hand, if the spinal nerve roots do not look impinged in any way, then this starts to look a lot more like piriformis syndrome. With that said, it's important to remember that a relatively good-looking nerve on MRI can still be inflamed, and reciprocally, a really bad-looking disc herniation with a lot of stenosis on MRI might actually not result in inflammation and therefore would be asymptomatic. Still, the MRI offers clues that help fill out the overall picture. Electrodiagnostic studies that test the functioning of the actual nerves, commonly referred to as an EMG, can also help to rule out a pinched nerve in the back and help to rule in piriformis syndrome, though even this test can be normal in someone with a pinched nerve in the back and can otherwise be somewhat inconclusive. But again, it helps to offer some extra insight into what is going on. In the end, a person with piriformis syndrome is typically on the younger side, has buttock pain and/or pain radiating into the back of the leg along the sciatic nerve. Their pain is usually not better or worse with sitting or standing, but may be worse with climbing stairs and walking uphill. An MRI of the spine typically fails to show significant stenosis or narrowing around the L5 and the S1 nerve roots, and the EMG generally doesn't show a big pinched nerve in the back. If all of these criteria are met, then piriformis syndrome becomes the working diagnosis. Now, the fewer of these criteria that are met, the less likely it is to be piriformis syndrome, and the more likely the symptoms are to be coming from the spine. The mainstay of treating piriformis syndrome is to stretch the piriformis muscle as well as the hamstring muscles. And for specific exercises that work really well to heal piriformis syndrome, you can check out our video on the best exercises for piriformis syndrome. Physical therapy can also be very helpful for piriformis syndrome because in addition to the therapist working one-on-one with the patient to learn and guide the therapeutic exercises, a therapist can use their passive modalities such as soft tissue massage, myofascial release, ice, deep heat, ultrasound, electrical stimulation to help release the piriformis muscle. A physician will sometimes perform a trigger point injection into the piriformis muscle using lidocaine to release the muscle. In the trigger point injection, the physician sometimes will add steroid to the injectate as a way of adding anti-inflammatory medication. And sometimes physicians will inject Botox or botulinum toxin for difficult to treat cases of piriformis syndrome that aren't otherwise getting better. But regardless of what sort of injection is used, if it's used, it should always be followed by stretches in order to relax the piriformis muscle, improve flexibility, and not only to get the pain better, but also, importantly, to keep the problem from returning. Another important point is that in many, if not most people with piriformis syndrome, either as a contributing underlying cause to the syndrome in the first place, or as a result of the pain in the second place, the hip abductors become weaker and then contribute to the problem. Now, if there's any instability in the hip abductors, it's important to safely strengthen them as well, and also to look for any other muscle imbalances and address those as well. Whenever you treat piriformis syndrome, you have to remember that if the piriformis syndrome is really a symptom of an inflamed nerve root in the back, then the symptoms of piriformis syndrome are just that, symptoms. And even the most diligent workup of the symptoms can sometimes lead to the wrong working diagnosis. And this is really important for doctors and patients, frankly, to keep in mind. Consider someone who appears to have piriformis syndrome, but they actually have a pinched nerve in the back. And they just happen to have a good-looking MRI. Now, you can inject the piriformis muscle in this person. The symptoms feel much better. But then, after a few days or a week or 2 weeks or maybe 3, the symptoms will return. If you aren't careful, the logical conclusion is that it's just a difficult case of piriformis syndrome, when in fact, it's because you have the wrong working diagnosis. If you don't course correct for this patient, well, then you'll just keep on treating the wrong problem and getting short-term and misleading and ultimately very frustrating results. As always, getting the right diagnosis is the key. You cannot treat what you do not recognize. So doctors always need to remember to consider investigating the spine further if the piriformis syndrome isn't getting lasting results from treating the piriformis symptoms. And this can be difficult to recognize because while the diagnosis may be wrong, there will be other people who really do just have difficult to treat piriformis syndrome. Sometimes a duck is just a duck, right? Not all piriformis syndromes are easy to get better. This is a great example of when it becomes really important for patients and doctors to have excellent communication together. And that's your 9-minute piriformis syndrome tutorial. I think we got all of it in the right time limit. If I went over, I apologize. I hope you'll agree it was worth it. And I hope you found the information that we went over here useful. And if you have enjoyed it, and if you've learned something, then please remember to like this video, subscribe to the channel, and tell a friend who might also enjoy it, because that's the way that we can spread good health information and achieve good health together. As always, if you have any questions that you'd like me to answer in a future video, or if you have any comments, you can reach me at drcooper@princetonsjc.com, Or, of course, please feel free to leave a comment in the comment section. Thank you very much.